Good morning everybody, and thank you for coming back after yesterday's event. What we're going to cover this morning is try and bring together some of what we introduced yesterday, and hopefully demonstrate a bit of how we interact as groups, so we're not working individually as silos. And so you'll start to see a bit more of why having the radiology, the information that we include in our radiology reports, why that matters, the information that comes from pathology, why that matters, and how it all fits together. Thank you very much for all those that sent their samples in to us and to the radiology. And by and large, they were very, very good. So we didn't feel that it was going to be particularly valuable to sit down and critique those, because actually the standard's already excellent. But hopefully from the discussion you can see what we think you should include and why that, what the impact of that is. So I'm going to just cover for the multidisciplinary meeting that we have for our cancers from a radiology point of view, but actually the parallels are true for pathology or oncology or whoever the involvement is as to what they bring to the meeting and what you need to make that meeting work well. Surgery. So, oh yes, surgeons. So I'm going to cover briefly what we think the MDT is about, what the radiologist's role is I'm going to cover, and also, as I say, what you need to make that meeting run effectively. So, multidisciplinary meetings has probably been the biggest growth area in the NHS, and they're now a vital aspect of NHS cancer care. They're considered to be mandatory for all cancers. They have to go through, and all cases have to be discussed in some shape or form in those meetings. And the purpose of it is to ensure that all of those patients are managed in the best possible way, and there's a uniformity of management, so that we bring in people who may potentially have originally been sole practice, working at the margins of groups, and it's to ensure that actually we're all doing the same things and offering the best care we can. Allows people to develop practice, share good practice, and hopefully identify areas that actually we can do better. So, as far as we're concerned, we have some national standards which are available for radiology. They're freely available if you search for the Royal College of Radiologists, but the NICE and other NHS sites have documents which describe what the standards of care should be and how best to deliver those for people. So what do we need as far as radiology is concerned? Well, radiology and pathology and surgery and oncology, they're all considered to be core members. What does that mean? Well, it means that you have to go to the meeting, or that you have to have somebody who's an appropriate representative at that meeting. And in fact, if the meeting doesn't have a radiologist and a pathologist present, then actually they're not considered to be core aid. The meeting doesn't go ahead. What we also need is somebody who's going to coordinate that meeting. Now, usually we have an administrator who will be our MDT coordinator, and they will ensure that the agreed patients are put onto a list well in advance. And you need to agree that. You need to have time to sort things out. And you need to make sure the right people are getting there. And it's very clear why that person is there. What are we trying to achieve for that individual at that time? So we are there to provide or confirm the staging which has been done. But actually, as I showed you yesterday, it's so much more than the T&M. It's actually about identifying features that will affect treatment options. You know, we're talking about a low rectal cancer, we're talking about sphincter involvement, margin involvement, we're talking about other adverse features. So, is this patient going to go direct to surgery? Yes, no? What kind of surgery? What are the things that I need to bring out in my report? What are the things that need to come out through the pathology that will influence the decision-making process in that patient, so they get into the right pathway at the beginning of their care, and potentially we'll review them again part way through their care. They've had the surgery, we're going to review the post-operative specimens. Was the operation the right operation? Was there any problem with it? Is there something that we didn't expect? What's the ongoing care? Is it just follow-up? Is it going to be chemotherapy? Do they need repeat surgery? Are we talking about pelvic exenteration? All of these things will come back through this meeting where we have a joint discussion to review those features. So we say at the beginning of that patient's pathway, we're going to be talking about resectability, and we need to ensure that we eliminate positive margins, confrontation margins. That's a sort of, we need to know that the radiology that we're providing allows us to, for the best surgery to go ahead. So you do need to be looking at the outcomes, and we know from having introduced this meetings that NDT discussion has had a very positive effect in reducing positive margins. It's not just because the surgery is improved, which has had a massive impact when we're going to TME, but it's about the quality of the imaging and the pathology allows that discussion to ensure that the correct patients get to surgery and the right operation is done. So we reduce positive margins. Why? So we reduce local recurrence rates. That's what we're trying to do. So we're going to be identifying from the imaging and pathology those patients that are suitable for radiotherapy and identify other comorbidities. There's no point producing a lovely radiology and pathology report actually if you then take a patient to theatre that should never have got there in the first place. So the patient's performance status and their suitability for operation will be discussed at our meetings. Quite a lot of that information will come obviously from the surgeon who's seen them in clinic. Some of it will come from other healthcare professionals that may be involved in their pathway. We involve a lot of us with clinical nurse specialists. They will understand the social circumstances for that patient, because that will have an impact on the rehabilitation afterwards. Have we involved stoma care? All of the other aspects which are involved in making sure that patient has a smooth pathway through their treatment. So what do I think you need to make it work? Well, you need time. You need to have time set aside properly, not only to attend, but to prepare for the meeting. You need to make sure that there's time potentially after the meeting to carry out any further tasks. Most of the time that isn't something that really affects me as much, but it certainly affects someone like Mark, so that we sit down, we have that group discussion, we decide that this patient's going to have this, this and this, and actually, oh, they need a PET scan, oh, they need their performance data to it. So that is paperwork, it generates paperwork. And for this to happen, and to make sure that it's consistent, is you need to know you've got time. And we pour over what we call our job plans, which is a prescription of what I do. That's, for me to get paid, I have to do this, and I agree that. But I make sure that I've got time, the right amount of time, in my job plan I'm going to deliver to do these tasks. Because if you don't have time, you won't do it properly. You also need to make sure you've got decent cross-cover, because I can't be at the meeting the whole time. So I need to make sure that my colleagues are involved, and they get to go to enough of the meetings so they know that actually this is what we do, this is the current T&M that we're using, this is what that particular surgeon likes to use, we understand about the surgical options. So you can't have somebody who comes once a year just to cover you when you're on holiday. They need to have proper cross-cover. That may be a junior member of staff or a colleague, but you need to know that they are regularly involved so that they can maintain those standards irrespective of who is there. From path and radiology point of view, you also need to make sure your IT works. There's no point turning up and saying, I'm describing to you, because you can't see it, what the MRI looks like. You know, the kit needs to work. You need to be able to get your cases. If you're working in group practice, where you may have 3 or 4 hospitals, those cases need to be sent to you in advance to allow you to make sure that you can project them. All the images are there. You can't make a treatment plan on something you haven't seen. part of our quality assurance process is that essentially it's a second reporting process. Even if it's done by me already, I look at it again for the meeting, get the presentation, cut down, make sure that we've got the right things to show the sagittal view that shows the anterior relationships, to make sure I'm showing where the levators are, whatever it is. But I need time, and I need to know that I can show that so that everyone in the room has the opportunity to see those. Reading the report does not give you that. So, and also I do have to have a rough idea of what I'm talking about. And I also need to know not only about the subject matter, I need to know my surgical colleagues, and I need to know my pathologists. Because actually, individuals are different, and I know that certain surgeons have strengths in certain areas. So if I'm going to be dealing with a patient that may have a polyp cancer, that may potentially have endoscopic resection or microsurgery of some kind, I need to know that that's done by that person, and they're less worried about the anterior relationships, they're more likely to stray anteriorly, whereas another one might be doing it, won't. Or is this patient going to need some other kind of reconstructive surgery? Do I know the plastics team, if they need to have flaps, what the other things are important? Have I looked at the vascularity beforehand? Do you think, well, this is going to be an AP, a lateral AP, they're likely to have a pelvic defect. This might impact where the stoma goes. So I'm going to look at the vascularity, I'm going to look at the inferior epigastric artery to say, well, actually, I think they've already got atrophy on one side, so if we put the stoma on the good side, they can't now have a rectus rotation, they can only have a gracilis flap. All of these things comes from knowledge, but also knowing the team and knowing what the surgical options are. So these are all vital aspects of my or our involvement in that patient's care. So preparation, as I say, is vital to make the meeting run effectively. We have maybe 4, 5, 6 surgeons, usually 1, sometimes 2 radiologists, pathologists, 1 or 2 oncologists. Palliative care is also part of our core, and they will come along occasionally. Have other healthcare professionals there. So you can see, actually, this is a big team. This is very expensive. So actually, I want the meeting to run quickly and effectively. We want to make sure that we don't spend time discussing the very, very straightforward cases. It's very clear-cut. This is a T2, N0, rectal cancer in somebody with a good performance status. Are there any issues? No. Fine, let's move on. We've got someone who's got a low tumour, adverse features, pathology doesn't really fit with what we're seeing on the imaging. Do we need to go back to biopsy? Those are the cases that you need to spend time on. So I need to have time to make sure that all the images and reports are available and they're complete. Finding out that somebody's had a previous cancer. Did you know this patient's had prostate cancer and they've already had radiotherapy? No, we didn't know that because they've come out of region. Well, I can tell you they have. They've had brachytherapy or they've had this. That means you're not going to have further radiotherapy. So the treatment options that you might normally be considering, you can't consider. So it's important that we go through the previous reports, find out a bit more about the history, because often we don't get that up front. So it's part of us is to make sure that nothing else has been missed. We each contribute to that. The pathologist will say, well, actually, I've got some pathology here, but actually, did you know they'd had a previous ovarian carcinoma? And actually, the cell type makes a suggested genetic variation. All of these things are things that we need to consider. But you need time to prepare, and you need to make sure that all those things are available. We do need the details of the history, and that needs to be upfront, not just presented at the meeting, because actually that will influence us on the kind of things that we're going to look for when we're preparing. So that needs to be collected up, long time ahead of the meeting. We have a minimum cut-off of 48 hours prior to the meeting. That complete list needs to be there, and it needs to say, why are they being viewed? What's the question that we want to answer about this patient? Now, it may be something as staging, first presentation, staging. Okay, so I know what I'm looking for and those sorts of things. But actually, it may not be the first review. It may be post-treatment. It may be for another reason. And just having a name on the list and maybe 15 examinations in a packet, I don't know what to look at. I could spend all day looking at that imaging. I don't have that time. And I may still not be able to answer the question which the person needed to know. So it's vital work when those lists are put together to say, we want to discuss Mrs. A, B, and C. Mrs. A is there as a first presentation, Mr. B is there because they've had their radiotherapy and now clinically they've got a recurrence. You know, that's a very different discussion and answer the question that I'm going to be answering. You know, other person's there, local recurrence, why? Let's go back to the first staging. What did we get wrong? And so it has to be very clearly described what it is that, why are we discussing that patient? So you don't waste time and you get the right bit. It's very important also is that there's a record of the discussion as well. Now, many of you already have very good cancer databases that information is recorded. But we have mandated is that if I review radiology, I will record in the radiology system what we have said, so that it's very clear that I have reviewed the imaging, I've looked at the initial staging, and I agree with it. I don't have any, you know, it is what was originally said, and I've clearly said who it was that looked at it. I've got my GMC identification, so people can look at after the time and say, okay, it was reviewed by him, when, at the meeting, and we know what the outcome was from the imaging. I will also record anything for us that has implications for imaging afterwards, so that when we go, because all of the further requests are done electronically for us. So if it says, I'm vetting for a new CT that's been requested, I can look at the NDT outcome that's appended onto the end of that imaging that says, new CT, specifically to look at pulmonary nodule in 3 months' time to see growth to suggest it's metastasis. So when I'm then saying, well, I don't see why they need another CT, they had one 3 months ago, it doesn't make any sense to me, what's the question? Reject. You know, so actually, by recording it, you've got an information trail for people to follow. You can also go back and say, well, actually, this wasn't right. Why did you change the additional report? So there's an audit trail to see about quality assurance. What do we do at the meeting? Well, we present the relevant findings I've described, and we answer the question that was asked. Hopefully it was the right question. And we may potentially update the record. So what I tend to do is I will record what I showed you just there, but I won't verify it. It will be left on our electronic system unverified. Because sometimes things come out of the meeting that we didn't realise. Did you know they'd had this? No, I didn't know that. Okay, well that now explains why it looks like that. It's because they had radiotherapy, or they had something removed, or there was some other information that actually drastically changes the interpretation. So that I would tend to record on the fly. And we keep a very close eye on the volume of activity in the meeting. The way that we manage it, because the time is very defined, is that we keep a very close idea on the actual volumes, because you can't have, well, just put everyone there. You know, they all need discussing, and 1 week you may have 40 patients. Well, okay, I run I'm part of the NUT for livers, and we usually do 60 cases at one meeting, but I've got time to do that. And we know how long it takes us to do 60 cases and prepare them properly to run it in a meeting. But I can't do 60 if I've only got time to do 20. So you need to keep a regular audit on workload to make sure you've got the proper time and to make sure that the right cases are being discussed and you're using those expensive resources wisely. So not infrequently you'll find that someone will pitch up and say, oh, I know they're not on the list, but could you just have a look at what do you do? Well, you could just say, no, I'm not doing that. That's probably not particularly helpful for your relationship with that surgeon. That's probably not particularly helpful to the outcome of the patient. But what you do have to bear in mind is that the reason why I spend a lot of time looking at these things in advance is because actually I need to look at them properly. And so potentially you can have a brief review and make a superficial comment on answering that question. But it needs to be very clearly documented. That's exactly what you've done. You haven't done a big review, you haven't looked through the imaging, but it needs recording. You know, this out on the fly was a brief review which has answered a specific question. And then really what you need to do is to go back afterwards. I mean, you could say, I'm not doing it now. You have told me this question. I'm going to go back to my office after the meeting and I'm going to answer that question by looking at it properly, and I'll get back to you and I can update it. And that's probably, somewhere between those two is probably the right thing to do. But what I wouldn't do is just say, well, I don't really perhaps try and do it, because you will make mistakes. We are all human, and when you've got lots of things happening at once, lots of activity, you will make mistakes. And you're not actually, you've got to remember there's a patient on the end of this, and you're trying to do this to make sure that you offer them the best care. And doing it in a shoddy way, not preparing, not doing it properly, is not in that patient's best interest. Quality assurance is a vital aspect of the whole process. It's really why NDTs came into being in the first place. So we encourage you to involve in an audit of the outcomes. You need to look at various different aspects from a radiology point of view, from a pathology point of view. Has there been a change between the initial assessment and the second review? And you need to have potentially some kind of arbitration process. Well, I've said this is T3B, you've said it was T2. Who was right? How do we decide who was right? What's the final arbitration? You know, if the radiology doesn't fit with pathology, well, is that because they've had chemo? Is it because they waited a year before their surgery? Did I have all the information available? Was there some reason? So you need to, I'd encourage you to make sure that you audit, and there are a number of things. That particular article I showed you from the Royal College of Radiologists has an audit process within it, and allows us to go back and look at the outcomes, look at the completion of the staging. We also would encourage radiology to make sure that we keep a record of what the pathology has said, because actually that should be our final arbiter. To say, well, you always get this bit wrong, you always miss vascular invasion. Well, that allows us to improve our practice. It allows us to address areas where deficiencies in what we do. So by auditing it, you know whether you are consistent with the expected standards and what individuals are. There will be some people who are very good at things, and then there will be other people, actually, they're always a bit ropey at that. Well, that's fine. We can address that, and we can support that to make sure that the standard of care is consistent and as high as we can achieve it within the resources that we have. I think it's very important that you review cases where there are positive margins, either those in microscopic or macroscopic disease, because some of that will be surgical technique, but actually quite a lot of it is due to poor imaging. If we haven't identified margins that are threatened, we ignore things which will affect the surgical outcome, we need to look at that. Go back and look at the R1 and the R2 resections and see if you can identify why is it. Well, actually, we didn't really make much of assessment of the pelvic margins. We didn't appreciate it was such a narrow pelvis. Didn't appreciate that I had a huge uterus. Or what are the other factors that may have influenced the margins being affected? And then hopefully you won't do it again. So that's a good idea. And I think, as I've said already, you need to keep an eye on the workload data, because inevitably these things tend to creep up. You need to make sure you've got proper time to run the meeting properly, and they're not discussing people that don't need to be discussed, not continually rolling patients over onto the next week because the person who was supposed to be there didn't turn up. So you need to have a process to ensure that the workload is consistent. So hopefully that's given you an idea of how, from a radiology point of view, but it does have relevance, I think, to pathology and to surgery, how we run our MDTs, and that it is a vital aspect of cancer care, certainly within the NHS, and that, as far as I'm concerned, radiologists are core at that meeting, and we're central to not only diagnosing and staging, but influencing that patient's ongoing management. There we go. So, I'm going to
Can I just make a couple of points, Bruce?
Yeah.
It's important to say that one of the reasons, he's been very kind to surgeons really, one of the reasons for MDTs is that from referral from the community, the pathway for 90% of patients is to come through a surgeon in the UK, first of all. rather than, say, a physician or a gastroenterologist. And so it's worth stressing the importance of the reason for the MDT is to stop surgeons making stupid mistakes. And he did mention that the surgeon operating on a patient who then gets a positive margin and then has to have post-operative radiotherapy, because we know that the outcomes from post-operative radiotherapy are worse. Patients who have it planned either long course or short course. And the final thing is that we have our hospital MDT for patients with colorectal cancer. We have, within that structure, we also have MDTs for less common cancers like neuroendocrine tumours and carcinomas of unknown primary. And then we have, for even less common cancers, we have a regional MDT which will cover things like anal cancer. And in some rare instances like peritoneal malignancy, we can refer to a national MDT process and send patients away if they need, say, a radical peritoneal operation accompanied by intraperitoneal chemotherapy. So it's a nationally governed structure for those reasons, and it also has within it different forms of MDTs for different types of malignancy. We also have what we call which doesn't sort of work quite as well as the cancer MDT, I think it's fair to say, but we have a complex polyp MDT. So when we take a bad polyp off and people like Morris have a look at it and it's got severe dysplasia, there's questions over whether it's malignant or not, adverse features, size of polyp, then they can go through a complex polyp MDT and inform either the surgeon gastroenterologist and the team what the best management is for that patient.
Okay, and I just wanted to add a few points in relation to pathology, some general stuff first, just to echo most of what Bruce has said, but from a pathology perspective, the MDM journey has really transformed our jobs over the last few decades, and anybody considering moving or taking a new job in a department, one of the first questions I want to know is what MDM or MDMs will I be allowed to or expected to cover? And really, because it's maybe unlike a patient, face-to-face patient job, this is a fixed commitment in our week. And a lot of the other stuff that we do keep this pretty flexible, so things have to work around this. Cross-cover is very, very important. But the MDM is actually the focus, really, of a lot of our pathology job plans. If somebody's going off, well, is cover available? Will I be back in time? These sort of things are very important. It's been also transformative because it actually is very useful at a variety of levels. Firstly, giving us the opportunity to engage with colleagues from other disciplines. You learn so much from that, especially when you become subspecialised, and actually it's well, actually I don't know that much about colorectal surgery and radiology, and you learn that at the MDM, and you know it, of course, pretend you knew it already, but it's really, really very powerful tool in that regard. And of course there's the social aspect of it as well, where you're meeting colleagues, and maybe this is more pertinent to radiology than radiology or oncology, but you're meeting colleagues that you otherwise will meet once a year, if that. So it's a real opportunity for pathology. The final benefit from it, which is a broader one again, is actually recruitment. So you're probably all aware of pathology disappearing from the undergraduate curriculum in a lot of medical schools, and a lot of students, a lot of doctors, a lot of lay people don't really understand the vital role that pathology plays in patient management, especially but not exclusively around those with cancer. So it's an opportunity for us to demonstrate our value to the team, and also for undergraduates or junior doctors to see that impact and potentially be beneficial to our profession going forward in terms of recruitment opportunities. So it's definitely something that the gut reaction as MDM startup is pathologist contact, are you going to make the MDM? And your immediate reaction is, no, I'm very busy, that just won't happen. So it certainly needs to be a planned process, but it's something that you really want to try and engage with and participate in, either directly or try and facilitate a colleague to attend, because there are plenty of MDMs. We heard a few anecdotes yesterday around issues here where an MDM can start up without a pathologist or without one member. And that's not really an MDM, and it really does undervalue the input of your profession into it. So if an MDM as a team thinks that it can operate with somebody reading out the pathology reports, that really undervalues our contribution to the team, and we should be trying to avoid that at all costs, and trying to make these things happen. The other thing to say is that you'll find that MDM journeys start off as one MDM, a GI MDM, and then they tend to proliferate and divide, so it then becomes upper and lower, and then the lower one becomes benign and malignant, an IBD MDM, a malignant one, then the colorectal cancer one sprouts off liver mets MDM, and what was one MDM 5 or 10 years later is 5 MDMs. So as Bruce says, keeping an eye on workloads, seeing these things happen. As soon as somebody talks about we want to set up an MDM, well, talk to my lab manager, job plan person, however it's operated. They need to get funding to make it happen, and really you don't say, well, I've got an hour's worth of funding, is that enough for you to do it? Well, so where's the meeting? Well, it's at this site. Okay, well, for an hour I could drive halfway there and come back again, but I couldn't actually stay for the meeting. So you do need to be resistant to signing up and over-committing and then not having the time to do it right, as Bruce was indicating. So I don't want to repeat a lot of what Bruce has said, but just a couple of points that I think are important. So you don't want to, gratifying as it might be for people who want your opinion on a case, your specific opinion, it's much better being part of a team where everybody's equally valued and the reports are right first time. So what I often say is, do you rush out of pathology? It probably applies to radiology. Do you rush out these reports, or do you wait till the right information and the right opinions are gathered so that one report goes out and it's correct? Because you really want to try and avoid the supplementary report issue. So MDM, more information coming out, or you review a case for the MDM and you disagree with the original diagnosis, then that puts out a supplementary report. That only has to happen once or twice for the judgment of the pathologist whose original report was issued to be questioned in general, and that undermining approach is not really very good. So what we're trying to do very much is, so for example, I don't service the pancreatic biliary MDM, but I do report pancreatic cases, including quipples and biopsies, core biopsies, and if I have any doubts or issues about those kind of cases, I will dream of authorising it until I've shown it to the pathologist that does that MDM, because I would much prefer get his or her opinion up front, make sure we issue a report that we're both happy with. So we might have slight disagreement, but better having that before the report goes out than after. And here we need to be transparent around it. The MDM review process is there for a reason. There should be no issues with access to slides, whether they're actually in your department or coming from outside, to allow this review to happen for added value. But actually the practical approach, which I'll come on to shortly, is that shouldn't really be necessary very often, because if you do this up front while the slides are still on the desk on the microscope, then this slide retrieval and slide review that is last minute, the best will in the world of getting this in time, that shouldn't really be as big an ordeal. So I would say try and get these second opinions up front, get it right first time. We all informally double report stuff, but maybe to ensure that everybody in the department is signing up to getting second opinions, consider as a department or as a team if you're subspecialised, insisting that all, for example, polyp cancers have 2 names in the report. That way it'll really sharpen attention and add confidence to the diagnosis. So double reporting, for example, we double report every new diagnosis of malignancy, even the most straightforward colorectal cancer biopsy. 2 names are on it. And therefore, when it comes to MDM, if it looks like a cancer radiologically, endoscopically, and there's a report saying moderately differentiated carcinoma with 2 names on it, I don't see the point in my reviewing that case, because it's still, if I disagreed in the off chance, it would only be one opinion against 2. So that sort of managing a high volume situation like that requires you to have processes in place at the initial reporting stage. So standardised approach obviously goes along with making sure everybody's doing the same thing. Multi-header sessions just to discuss issues around some of the subtle stuff we talked about yesterday, and we might mention it again in some of the case presentations around interpretation of polyp cancers and tumour deposits and so on. That will bring uniformity or standardisation both to assessment and interpretation. So you really don't want surprises, especially if we ask for the list 48 hours in advance, you get it 24 hours in advance. You actually get to look at the slides an hour in advance. That's when you don't want there to be surprises. So practically speaking, so MDMs, depending on their size and complexity, whether they're
all local cases or whether there's external cases, then determine really how practically you can function time-wise at the minimum time you need this beforehand. Certainly having appropriate admin and clerical help, this will all depend on your IT systems, and devising a system that's efficient is hugely important. So a very practical point, at an even more basic level than Bruce described, if you have a list of 40 patients but there's actually only pathology available or required for review on 20 of them, it's very useful to know that up front. So if you can actually get an indication of that, that will save a lot of hunting around for pathology that doesn't exist. Similarly, if you want to go a step further, and the cancer tracker and coordinator who does our meeting is kind enough to include this, so he or she will have to be aware of patients' back history, looking for other investigations and what's been done so far to populate the history. So he or she can very easily copy across the relevant pathology number just to get you started. So that's probably the most relevant, most recent pathology sample. But what is important is that is just the starting point, because we do have to then have a look at the patient's back history, which probably will be more visible within pathology lens than it will be to the overall team. So you may be aware then that actually lobular cancer diagnosed, breast diagnosed 15 years ago might or might not be an issue. So I tend to do quite a thorough review of all available pathology reports, but very minimal slide review and really only selected cases. And then the last point is around image presentation at the MDMs. So I generally find that the other members of the MDT, they're not particularly interested in the, try as I might to infuse them, in the actual H&E images. So maybe a polyp cancer, but I very rarely find, usually heads go down at that point rather than up. They're much more interested in macroscopic imagery. So we talked yesterday about the importance of macroscopic images. They really are popular, and I'm sure Mark will agree with this, that it's those images. Show me that marginal that you call positive, fair enough. Show me that intramesorectal TME, fair enough. These are the images that I think are useful to feedback and improve that quality. Okay, that's all I have to say. So will we? Any other comments?
I think the only other thing about the organisation is just a simple thing, which seems obvious, but it's worth emphasising, is that when the lists come out, is putting them in order. So for those cases that don't require any pathology, but require imaging, have them in a section, so that actually the pathologist may not need to be there for the whole meeting. Usually the radiologist need to be there for the whole meeting, but it's allowing people to use their time more profitably. So that's how we run it. We tend to run it. It's radiology only, it's radiology and pathology, and then a pathology only section. And in fact, often what happens is that some of my colleagues, when they get to pathology only section, will leave. I tend to stay because it's my part of my QA that I can see, oh, well, this turned out to be that, and we got this wrong, and so that's my opportunity. But by putting it in order, it does allow people the opportunity to potentially not attend to be there for the whole meeting if they're not needed, because there's plenty of other things to do usually. But being organised rather than just having it as a whole mixture makes the meeting run far more smoothly.
And that includes the surgeon, who most of our meetings are organised, chaired by the surgeon, and if they don't prepare the cases beforehand and have some prior knowledge of cases they may not be responsible for themselves, then you soon find that out. And we can't run our meetings without these two people in the room, plus particularly the oncologist as well, who's not at this particular meeting, but we need those four groups as an absolute basic minimum to make any sensible decisions about these patients. Preparation is absolutely key.
Okay, shall we move on to the case discussions?
Yeah, just one. So it was 10 past 9. So I guess what we'll have So what we're going to do now is we're going to present some cases in a way that probably will not be wildly dissimilar to actually how the meeting would work. possibly without some of the banter that goes on. So, excuse me. So the first case that we've got is of a patient with who presented with some rectal bleeding, and they went on and had review in clinic and were found to have a polyp, large polyp in the lower rectum, which endoscopically had features which were concerning for a tumour. So the patient was then referred on to have a biopsy was taken at the time, and then they were sent for MRI staging. So I'm going to hopefully show you that. So these are representative images. And what we have here is this large polyp. And so what will have come through in my initial review, and hopefully in the report, is the morphology of the polyp. So this is pedunculated, appears to be pedunculated. And I'm looking at its relationships. So this is where, this is the anacoccygeal raphe, on top of which is the Valdi's fascia. I want to know, can I see any evidence of invasion on this? But this is a difficult area. This is a low polyp. You can see how the rectum is sitting posteriorly. So I really need to scrutinise this very carefully to ensure that I'm not missing anything, any potential invasion. So we'll look at the other orthogonal views, make sure that we're reviewing that, and you can see. So we've got this polyp. Now actually, in this view, I can see where the stalk, I think, is attached. Having the clinical data from the endoscopic finding, where is the polyp base? Because actually it's not always easy to see on the radiology, and you're sort of, you know, the last thing you want is rectal polyp, stage. Well, that's, yeah, thanks. Where was it? Is it upper, lower rectum? You know, because actually they can be really difficult to see. And so what we don't want to do is to start reporting, you know, one of the rectal folds as some kind of polyp lesion because we thought that's what they were looking at. Or staging. They've removed the polyp already, and actually there is no polyp left. It's already in the pathology department. You know, these are the kind of things which are very unhelpful, but happen rather regularly. So this one, as you can see, I think the muscular appropriate here is very well defined. So I'm already into the level of thing. Well, I think this is no worse than T2. There's no features here to make it do this T3. And actually, I think that on the layers, certainly it may not project, that I can see the muscular appropriate actually really very well on its inner margin. So can I see a clear submucosal fat? Well, not clearly, but in fact on the axial view, I'm not seeing submucosal fat. So this is, if you think back to my T1 tool, this is one of the cases where you just don't see much fat in the submucosa. So making a difference here between polyp invasion, be it a Haggett score, so this is where those are polyp cancers on pedunculated polyps, or the Kikuchi, so the sessile polyps, that becomes relevant. So, but what I would be saying about this is I think this is T2 or better, and then I'm going to be looking for other things that we might be worried about. And in fact, we go, if it's on the axials. We're looking at the vessels. Are they clear? We know already that the incidence of extra EMVI in polyp cancers is very low. But it's worth looking, because actually if I've got the stage wrong, and it's full thickness T2 or early T3, and I see MVI, that is, it's changing. It's going to change how the management, because that patient can't have organ-sparing surgery. The other thing we're looking for is for the polyps and for the nodes. Now, this one is away from the margin. It's round, but it looks relatively homogeneous, as I can see. So I would measure it. How big is it? It's greater than 9 millimetres. That we're going to call that positive using the ASDAR criteria. If it's between 5 and 8 millimetres, I need to see some other morphological features, be it mucin, be it round, spiculated, heterogeneous signal. It's going to make me confident to say I think that's a positive node. Now, to me, I'm not sure that is particularly positive. It doesn't really have any features. We'll go back to the sagittal again, because where you're looking for your lymph nodes is within the mesorectum, but along the vascular drainage. So if we look on the, you can see very nicely the superior rectal vessels there. So we go through and we say, well, actually, there's that. There are two nodes. Now this one, you know, they've both got intermediate. They're okay, but there was another one somewhere, I'm sure. This one here. Okay, now this node, it's small, but it's round, and it's heterogeneous, and it's got a slightly spiculated margin. So that fulfills the criteria for us to say, well, I think that node's involved. So for this patient who's got a polyp cancer, we're now going to discuss, well, did you have the initial biopsy of the suture? So the initial biopsy is now is the taken from the top of the polyp is adenocarcinoma. So Mark will now, we will then get into this discussion of how we're going to manage this patient, because I'm going to stage this as T2 or better, because I'm struggling with the polyp stalk morphology. Don't think we've seen it well, but I think the muscularis propria is intact. I think the inner aspect is intact, so this could potentially be a T1 cancer, but I'm worried about that node, and that pushes us into a different, potentially into a different area.
So lots of questions have come into my mind. Let's say I'm a surgeon in the meeting and I may or may not have seen the patient, and that really is absolutely important. So if I have seen the patient, I would say, well, Bruce, we know that these polyps low down, benign or malignant, are very difficult to interpret on MRI the lower down they are, particularly those ones sort of sitting on the pelvic floor. That actually, the finger, this educated finger, might tell him actually that does feel tethered, or dare I say even fixed to that bit of levator that it's kind of sitting on right low down. So if I haven't seen the patient, I would say, who's seen the patient? And if unfortunately no one's seen that patient, I think the next step really with adenocarcinoma and what he's saying is to see the patient. Because then I'm thinking, okay, who is this patient? How old are they? Because the next thing is a lot of our patients, I'm sure yours are exactly the same, will be, let's say, in their 80s, may have a considerable list of comorbidities and drugs that they're taking, in whom a radical excision is going to be a major undertaking with a significant risk of comorbidities and dare I say it, mortality. And on the other hand, it might be a young, fit patient in whom one is going to adopt a very radical approach. And you know, I look at the second node I think you pointed to on sagittal, I'm thinking about the margin for that node, which looks to me like it might be close to my surgical margin. So I'm actually starting to move things on and think in a younger, fitter patient about preoperative neoadjuvant therapy, so long course chemoradiotherapy, if we think there's a higher risk of locoregional recurrence and a need for an operation whom the chances of that happening are minimised to the best of our ability.
So with respect to the node, we talked about the morphology of the node, and we thought that it was potentially involved, which is guiding us down. But the margin, so we know it's 2 millimetre cut-off. Is it greater than 2 millimetres? Is it less than 2 millimetres? Is it involved in the margin? Because that will again guide us. Now you might think, well, do you know, I don't feel particularly comfortable about the imaging of this node, and if that is the thing that makes our decision, then potentially you might want to consider something else. Would you do a PET scan? I mean, and certainly occasionally we'll do a PET scan to say, well, okay, that node is the thing that's going to guide us between doing organ sparing approach, so a local resection, or a major operation. So we would consider actually doing a PET scan. Now the downside of it for this is it's very small, and the metabolic activity is likely to be relatively low in such a small thing. So it may be beyond the margins, beyond the sort of resolution that we can get from PET. But those are the kinds of things potentially that we would talk about.
Can we just take it back a step? Because the other thing we're confronted with, especially for these low polyps, is the borderline malignancy. So we like our surgeons, like radiologists and pathologists, to be off the fence. You know what I mean? So to be decisive, to give us a definitive opinion. This is cancer, this is not cancer. That node is involved, that node is not involved. And sometimes, especially, I've just done one very recently, a local excision of a query benign polyp that turned out to be malignant because I took a whole specimen biopsy. So occasionally we might actually, the decision might be, especially in an elderly patient in whom that might be the only therapeutic option, let's go for a whole specimen biopsy, a transanal approach, either microscopically with a screen or directly if it's very low down, to get that whole specimen out. And very occasionally we may actually refer to a regional person. In our region there's a pathologist in another hospital who has a national reputation for sorting out very, very difficult polyps, where there's usually stuff in the stalk that because of torsion and trauma is very, very difficult to interpret. That's my surgeon's sort of amateur sort of interpretation of things. But what we want these guys to do is to come off the fence and say, this is what's going on. And Bruce is one of the most decisive radiologists I've ever worked with. So when we say, is this no positive or negative, he'll generally give you an answer. But what we want you guys to do is to give us the answer about a no, with or without further imaging modalities.
I just make a comment about that, the diagnostic certainty or uncertainty on biopsy. So often you'll find can come under a bit of pressure on the MDM. Well, is this definitely cancer? Can we go ahead, whether that's with surgery or oncology? And generally, the issue for colonic tumours is that if this is from a lesion that's not endoscopically resectable, well, the actual suspicious adenocarcinoma versus adenocarcinoma distinction is probably not important. There's enough there on other modalities for the patient to go for surgery. On the rectal side of things, or if oncology are going to be involved as the first line, generally it's more important to have a definitive diagnosis. I'm particularly keen in the setting of rectal cancers. If a patient might be going for non-course chemoradiotherapy before any further surgical intervention, or watching rate or whatever, then we have a diagnostic biopsy, because there's a small but significant chance that that patient could have a complete response to treatment, and then you never have any confirmation of adenocarcinoma. You get a sample that's equivocal, suspicious but not diagnostic, and should there be any need down the line to do any molecular testing, like RAS testing, or whatever the new kit in the box is going to be in that regard, then you really want to be able to do that on a diagnostic sample, so that you've got maximum confidence that there's been tumour DNA tested and enough of it that you can actually believe the results. So I often get asked, say currently we're doing RAS testing on quite a few cancers because of potential for anti-EGFR therapy, and then stage 4 disease. Can I do the result on a non-diagnostic sample, say it's suspicious or just hyperdysplasia? And I think the answer there is that by all means you can test that sample. If you find a mutation, you can believe that that is a RAS mutant tumour. If you don't find a mutation, there's a bit of uncertainty there. So RAS, before you can confidently say RAS wild type, you're probably better getting another sample. And then there's a practical element to that, because it inevitably takes at least a week to get a molecular result back. By that stage, you may well have a chance to do a repeat flexible sigmoidoscopy and get a better sample. And it's amazing how second time round the samples are always a lot bigger and better, and less need for pathologists to equivocate. So I think that's an important practical point.
The final thing which you've sort of alluded to is that you might be wondering, about the role of endoscopy, but most, if not all, colorectal surgeons in the UK do endoscopy, colonoscopy, and some of those do endoscopic mucosal resection. A very few of them might do more complex techniques like ESD, and so we don't often have a gastroenterologist in the room, but we always have surgeons that also do endoscopy. So you might say, even in a adenocarcinoma biopsy, well, actually this patient is 85, we know they're not fit, so we might actually go for an endoscopic mucosal resection for a malignant polyp of the submucosal plane as a means first to reassess the resectability of the lesion and see if it's possible to do it that way, and to use as a potential treatment arm. In a lot of countries, that would need to have the contribution of an expert gastroenterologist.
So a couple of things that come out from that discussion, from the last point, is so when you're setting up your MDT meeting or refining one you already have, having the ability to look at endoscopic pictures that have been acquired is vital, because if the pathology says, okay, I've got superficial fragments of a high-grade dysplasia, but I don't have any evidence to suggest invasion, but it's a pretty ropey sample, we'll look at the pictures and you say, well, okay, on the imaging, this looks like a cancer. And then if we've got the endoscopic pictures, you say, well, that looks like a cancer. And looking at those two together may be enough to push that patient straight to surgery. But I would echo exactly what Morris has said, is that actually, usually, the best care is to get proper biopsies up front. But the endoscopic features will undoubtedly influence how those things are managed. And the more you get used to the fact that, sorry, I just put my foot on. The more that you get used to the importance of polyp cancer treatment and T1s, the better you get at looking at the MRIs, because you start to understand what the mucosal planes are, and that you can see them, and you can, not always, but there are the features that will allow you to influence. So I think this is probably potentially organ-sparing surgery or approach is possible for this patient. Now, the other point I wanted to bring out was Mark likes the fact that I come off the fence. But there's no point coming off the fence if you always dive in the wrong direction. You need to know how good you are. And that comes from audit, and it comes from feedback, effective feedback from the surgeon, the pathologist, and from your colleagues. You know, where are my areas of weakness? What do I always get wrong? And then when I know that, I can do something about it, because there's always things that we can do to improve the way that we work. But you don't do that without insight, and that comes usually through decent audit and feedback and communication between colleagues to say, well, actually we disagreed with this and we had a bit more information. You need a decent coping strategy to how do you feed back to a colleague who may be slightly thorny and a bit doesn't particularly like being told that they're not right. So there are forms of words you can use. You know, following additional clinical information, we decided that this was the thing. So now there may or may not be additional clinical information, but that softens the blow. Because actually you're all in the team, and actually the outcome you're trying to aim for is that the patient gets the best care. So if I start having a fight with him about it, that's not in the patient's best interest. It might be amusing for us for a short time, but it disrupts the meeting. But actually giving people feedback, which isn't always what they want to hear, you do need a decent mechanism that does that in a reliable way to allow people to improve their education. Allow them to reflect on it as well. It's very much part of GMC, the part of the way that we practice is reflective practice. We look at what we do and we think about things that have gone well, things that could have gone better, and then try and either do more of the good stuff or avoid the bad stuff. As far as that node is concerned, do I think it's positive? No, I don't. Because what I don't want to do is for you to go away thinking that that node I've shown you, I would have definitely called positive. We're going to call it positive for the purposes of this case, because it makes the story fit together, all right? But I would be very equivocal about that polyp if it was real life. And I would record accurately the morphological features and the size, and then we would have a discussion about that uncertainty. because that's important, So why don't you to go away, you say, well, he showed this picture and he was adamant that it was positive. That's not the message I want you to get about that particular point. But it gives us a case.
I guess it's managing that uncertainty, so you're sufficiently worried about the node to push for surgery that you would be uncomfortable leaving it behind. So even though it's not sort of equivocal, I'm sure it's fine, but just leave it. You're concerned enough about it, even though clearly you can't be sure.
So, Cyrus has told me that I've overstayed my welcome. So we'll go on to, so for this particular case, the way that we put it together is that we felt that there was uncertainty about the node and patient choice, important factor. We decided to proceed to surgical resection. And so, pathology,
Yeah, I think it's so we see it the whole.
Actually, do you want to, so you can use the
Yeah. So this is clearly a resection specimen rather than polypectomy, and there we go. So this is the tumor. The first thing to point out is that so the polypoid lesion has a nice ulcerated depressed surface, and that's helpful because that's why the endoscopic biopsies were diagnostic here. So if you have a polyp cancer, and we frequently do see in this, where this stuff goes all the way around and is intact, then no amount of biopsies are really ever going to make a diagnosis of that. So usually in a PT1 cancer setting, you don't have diagnostic biopsies. So this case was unusual from that point of view, and clearly having a confirmed diagnosis of adenocarcinoma because of biopsies taken from in here has been helpful in the discussion. So if you sample here, this is basically just tuberous adenoma lobe dysplasia on either side, and then this is given way to this adenocarcinoma here in the head of the polyp. So this is the kind of polyp cancer, PT1 cancer, where you would think in another setting we could probably quite easily have done a polypectomy and removed it intactly because it has quite a good stalk, and it's been the other factors, principally the lymph node concerns, that has pushed to surgery. But just from the correlation with anatomy here, so this is our muscularis propria, the two veins of it, so tumour has to go all the way down into here to make a PT2. So there's this whole zone of clearance, and this is actually a textbook Haggard level 2 polyp cancer, because Haggard level 1 is into the head of the polyp, 3 is into the stalk, 2 the neck, and 4 would hit the submucosa of the background colon. So the muscularis mucosa is this little fine line here that we have to infiltrate into submucosa to this level to make it a Haggard level 4. So this is a Haggard level 2 polyp cancer. And it happens also within the neck to have lymphatic invasion here. So this is a small venular channel in the lower left, red blood cells in it. Here's a lymphatic vessel with tumour in it, in this space with no red blood cells, but clearly lined by endothelium. So this is lymphatic invasion. Now in this context, this is irrelevant really because we've already got a regional lymph node dissection. This would be a very important finding, as all the pathologists would have prepared yesterday, in the setting of a polypectomy specimen, because lymphatic invasion is now fairly well established as the strongest predictor of regional lymph node metastatic disease in a polypectomy specimen. So if that's the kind of finding where if this patient had been treated initially by polypectomy alone, and there were no issues with concerns about lymph nodes on imaging, then the finding of lymphatic invasion would hopefully have prompted us to go back and reconsider surgery as the second step in management. So we've got the highest hazard ratios here and all these histologic features. Lymphatic invasion, the strongest predictor, perhaps makes perfect biological sense of regional lymph node metastatic disease. The other things we tend to look for are poor differentiation. Some of us are interested in body width of invasion, other features that are a bit softer. And Haggard and Kikuchi are really, they're really qualitative or descriptive measures of invasion that have been around for a long time. I've just shown you a beautiful example of a Haggard 2, and
in practice, they rarely look like that, so it's actually quite difficult to apply those two for some cases, which is why we've moved to a more quantitative approach. And certainly this is very popular in Japanese practice, where we're basically width and depth of invasion are the important parameters there for management. But then we've got lymphatic invasion in this case, and that would be another that would make Bruce's lymph node even more suspicious. And when we find it, we see that it is involved in metastatic adenocarcinoma, this rim of subcapsular deposition of tumour within an enlarged lymph node. Incidentally, I won't dwell on this in the interest of time, but if in doubt about lymphatic invasion, you can confirm it with immunohistochemistry for this marker D240, which specifically stains endothelial cells of lymphatic channels, as in here, but doesn't stain the endothelial lining of veins. So this is a very useful marker for confirming lymphatic invasion. We went through a phase and did a study looking at double immunohistochemistry with a red stain here being epithelial markers and then D240 as applied as one coat of paint to try and pick up subtle lymphatic invasion. And we did this and produced beautiful images like this, but then we found ourselves with the problem of the significance of this. So this is one tumour cell, and it wasn't picked up on imaging, which surprised me. But you know, so the problem we had that if we look really, really hard and find a case like this, then is that with the same clinical significance? Is this patient the same risk of reaching lymph node metastatic disease? And the practical problem we had was to go to the MDM and said this, so you think you should have surgery? And we're in the unknown territory there. We just don't know. It hasn't been shown. Very hard to get evidence based on PD-1 cancers. A lot of them here are small series. But these markers are there if you're equivocal in H&E, but we don't now do them routinely up front because we're finding this practical problem. But we do make mistakes.
That's a real issue though, because these guys both give us increasingly higher levels of discrimination and find increasingly more subtle evidence of possibilities of problems for the future for that patient. So you can't make those things in isolation. We have to know. So I might say, well, okay, but that time finding, this patient's 45. And then Bruce will say, right, okay, well, let's do a PET scan now as a baseline. It's likely to be negative in terms of extra resectional lymphadenopathy, for example. And let's do an interval scan in, I don't know, it'll say 3 or 6 months. And then we'll get, and then it will be patient-centered. So we get the patient back the following week. In our case, we discuss on Thursday, come back to the clinic on Monday, and there's a surgeon plus the specialist nurses there, and we'll say, you know, we've done this, we've got negative margins, the scans are all clear as we stand at the moment after your surgery, but we have a concern, and our colleagues in our meeting last week think we ought to do a scan at 3 months and a PET scan and something else. Obviously, we haven't talked about sort of baseline bloods, and sometimes the CEA is quite a useful marker if it's been raised at the point of diagnosis. It can be used as a sign that maybe trouble is brewing. So we don't ever do things just with him saying, I found one cell in a lymphovascular channel. It's all a team decision. Of course, the oncologist who's not here is also part of that process as well. And these kind of patients, well, actually, they're young, we're going to get them back, and we're going to say, you might have a small chance of benefiting from post-operative adjuvant chemotherapy. The chances are small. What do you want as a patient? These are the risks of having chemo for you. Mortality, morbidity. What do you want? So it's very patient-centered, hopefully, in most cases. And this is why it's important to say surgeons used to entirely own these decision-making responsibilities to refer to oncology to get scans. It's been taken away from us for the right reasons, so these people inform our decision-making pathway.
So the outcome for that case then was PT1, N1, or 0, one lymph node involved out of 15 or so, and AGA2 cancer, so I guess the follow-up there will be just surgical reviews with no further treatment required.
Yeah, so, I mean, as Bruce will say, we've got a well-established pathway of annual scans at 1 and 2 years, and sometimes on the 5th year, especially if they've had neoadjuvant chemoradiotherapy. Colonoscopies, we've got established guidelines on when they should have further surveillance colonoscopies. Usually after an annual staging scan at 1 year, we'll get the patient a colonoscopy, ask for one rather, request one, and make sure there aren't any metachronous lesions, benign or malignant, affecting their large bowel. And so this is how it all goes ahead. And then a lot of patients actually come back to a nurse-led clinic where there aren't any major complicated issues, and they're addressing a lot of holistic things about their wellness and diet and lifestyle to try and make sure they're well adjusted to the diagnosis and have a clear understanding of what's going on. Sometimes doctors don't have the time and aren't very good at explaining things in the right detail.
So we're going to take a break there to allow some coffee to be imbibed, and then we'll come back. We've got some other cases that bring out slightly different issues, but this is how we're going to run it. Is there any specific questions that you might have about how we do things, and or the practice that you have that you think, well, actually we do it like this, and I think actually that would be a much better way. That's part of sharing your experience and good practice that you have. That's part of why I wanted to see the reports and things, is to see where you are and what we can learn as well. So have a coffee now.